Hi, I'm Eileen. I'm a rising sophomore at Duke, majoring in neuroscience with a certificate in science and society.
And hi, I'm Hannah Shuffer. I'm also a rising sophomore at Duke, and I'm looking to double major in chemistry and cultural anthropology. And our mentor this summer was Dr. Janet Prue-Bettger, and we spent our summer looking at a social prescribing program among special populations at a federally qualified health center. So just to give some background, as you can see in the diagram on the right, social and economic factors are more important to health outcomes than clinical care. And social prescribing is the referral of patients to non-clinical resources in order to address unmet social needs. So we were looking at the Help Desk program, which is a social prescribing program. And in the US, due to social prescribing's infancy, less is known about its impact among high-risk subpopulations like Spanish-speaking, Hispanic, or older adult patients. And just within the broader context of North Carolina, there's the Healthy Opportunities Initiative, which for those who don't know about it, it allows a certain amount of Medicaid funding to be used to cover services addressing social needs linked to health and health outcomes. And there's also NC Care 360, which is a statewide coordinated care network and shared technology platform that aims to electronically connect individuals with unmet social needs to community resources and can be used to track these individuals' outcomes. And so the program that we performed our research on, which is the Help Desk program, its ultimate goal is to integrate with these state initiatives and perform follow-up calls for every individual that doesn't connect with the resources they were referred to through the NC Care 360 program. And this is important because it ensures that the individuals within the NC Care 360 system are being fully supported. So our research is important because we just want to improve and perfect the Help Desk program as it heads towards this greater purpose.
So just some more background on the Help Desk model. So this is what this diagram is showing. So Help Desk currently partners with Lincoln Community Health Center, which is a federally qualified health center in Durham. So patients who are screened by Lincoln's behavioral health team, they can be screened for their unmet social needs, and case managers there can actually refer patients to relevant community resources. And the case managers can then also refer patients to Help Desk. And student volunteers at Help Desk, they act as community resource navigators to perform follow-up calls, to connect with patients and help them connect and navigate with those relevant resources. So like Hannah mentioned, there's less understood about social determinants overall among special populations like older adults and Hispanic and Spanish speaking. And these characteristics really need to be taken into consideration, especially as social prescribing programs like Help Desk continue to develop and improve. So the purpose of our study was to first identify social determinant characteristics among these special populations and assess the reach of Help Desk in meeting those needs. The setting in the population were patients who were screened by Lincoln Community Health Center case managers in the first year of Help Desk's program. And our study design was a retrospective cohort study. So we reviewed existing data from the first year of Help Desk's implementation. And we also would like to point out that the results that we are presenting today are all based on preliminary data.
So for my study, our goal was to determine if there was a significant difference in the amount of Hispanic and Spanish-speaking patients referred to the Help Desk program, and if these differences did exist, to make recommendations on how to eliminate the disparities in referral. And this is just important because 13.7% of Durham's population is Hispanic, and that number is growing, so this makes up a significant portion of the Durham population. And these are just the preliminary results, as Eileen mentioned. But as you can see, we can already tell that the non-Hispanic patients were referred proportionately more than Hispanic patients. And within the Hispanic population, English-speaking Hispanic patients were referred proportionately more than the Spanish-speaking Hispanic patients. And so again, since this still is preliminary, these are just our preliminary conclusions, but if there is this disparity, then it's important, in order to eliminate the disparity, it's important to inform case managers so that way they can be more conscious and proactive when they're interacting with these patients. Furthermore, implementing cultural literacy training for the case managers should help to improve the patient-provider relationship. So that just means helping with communication and trust. And also developing more clear guidelines for referral is important. Currently, they're quite ambiguous, and that ambiguity may be allowing for this disparity to occur.
So the group that I looked closer at was older adults, and especially in an aging population that places burdens on health systems, it's really important that effective care integrates non-clinical interventions like Help Desk. So I had three main goals in my project, which was the first one to assess responses in social risk screening among older adults and then compare them to younger adults to see if there are any differences. And this was important because social determinants are generally less studied and understood among the elderly. And the second was to evaluate the reach of help desk by comparing social determinant characteristics of older adults who were and were not referred to help desk. And finally, I wanted to assess how and whether community-based organization referrals were resolved among older adults 2 weeks after their first clinical encounter and referral to help desk. So figure 1 shows the patient characteristics among older adults and compared to younger adults, and the second include social risks. And you can already see that there is a wide variability of social determinant characteristics with some differences to younger adults as well. Compared to younger adults, older adults were more likely to identify as Black and African American race. They were also more likely to report lower household averages and live alone, as well as more likely to report unemployment due to either retirement or disability, but they were also less likely to identify as Hispanic and report limited English proficiency. And when I took a closer look at demographic patterns among older adults, I also found that older adults who identified as Black or African American were more likely to report at least one unmet material need, as well as multiple unmet needs compared to those identifying as other in the race category. And among older adults who were unemployed to disability, almost half of them reported at least one unmet need, with another great proportion reporting multiple. And then in the comparisons between referred and non-referred older adults, I found that older adults who were referred to help desk, they were more likely to have a lower household average or live alone. They were more likely to be English speaking rather than another language. They were more likely to be of non-white race. They were more likely to report food as an unmet need, and they were also more likely to report access to medicine and healthcare as an unmet need. So just want to drive back the significance of our project. It's important, like Hannah and I mentioned, that social prescribing programs take into consideration the needs of higher risk populations to inform them as they develop and improve to ensure that the programs can really best serve its diverse patient population that they're seeing. The Hispanic population, for instance, is a growing population in Durham, so Help Desk really needs to change its capacity to make sure that they're meeting this increasing need. And this is a change that is actually being reflected currently, as their recent cohort of volunteers have been more focused on incorporating Spanish-speaking volunteers. Older adults also have unique needs like multimorbidity, higher cognitive needs, and cumulative effects of social risk over their lifetime that current standardized screening tools like help desk use like PrayPair might not actually account for. And so it's really important to take into consideration the needs of these higher risk populations. And social prescribing overall is really valuable, especially as health systems will more likely need to rely on the intervention of non-clinical interventions so that they can best support patients beyond their first clinical encounter and really address the issue of social determinants of health.
So for the future steps for both of our studies, for the Spanish-speaking study, it's important for us to perform our analysis on the clean data and then analyze the patient characteristics of the various subgroups. So that's looking at the Hispanic population to the non-Hispanic population and looking at what they each identified as their needs. And then for the older adult study, since they've already looked at the identified needs, it's looking to see once the older adults were referred to these resources, if they ran into any, or if they had any barriers when trying to access or use these resources. And thank you. We're glad to take any questions.
Yeah, that's great. Okay, so we have some time for questions from folks and want to open it up.
I just wanted to say thanks to this group. I think everybody recognizes working with clinical data is messy. And these, you know, as rising sophomores, you guys did a great job.
That's great. And so actually, and this is a question for both, you know, Janet and Hannah and Eileen, is this is part of the kind of do you have the best connections help desk going forward into the academic year?
This was more of a conclusion of last year's, and next year we're going to work towards scaling NC Care 360 in the Duke Health System. So this is really critical data to support how we're scaling these interventions and these policies in the state, recognizing the likely health disparities that they're creating just in implementing them themselves. So this was really critical work, thinking about how do we focus on high-risk populations. I'm really thankful that they wanted to dive in here.